Today our guest speaker is Dr. Girish Kamath from Dharwad. He will be lecturing on approach to diagnosis in a case of Pancytopenia. This webinar is brought to you by Mumbai Hematology Group. It is supported by Sun Pharma and managed by Perfect Square. I thank Mr. Arvind Suri and the team from Sun Oncology, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Shweta Bansal from Mumbai, our guest speaker, Dr. Girish Kamath from Dharwad. All our discussants were themselves eminent hematologists, medical oncologists, or hematologists. New participants for spiritual Sunday morning if you are from India, and afternoon or evening if you are from the other part of the world. Just to introduce you to the next weekend webinars, on Saturday, 11th February from 7 p.m. IST, we have Dr. Deepa from Hammersmith Hospital, London, speaking to us about British guidelines for thrombophilia testing. And the next day, that is Sunday, 12th of February, we have our own Dr. Reena Das, professor at PGI Chandigarh, speaking to us about uncommon hereditary anemias. Our discussants today are very important people, and they have been put up alphabetically over here. To introduce them briefly to you, we have Dr. Aditya Jandyal from PGI Chandigarh, Dr. Akash Khandelwal from BLK Max Hospital, Delhi, Dr. Alok Shetty from Tata, Mumbai, Dr. Amit Jain from BMT Center, Thalassemia Care Center and Pediatric Hemato-Oncology Center at MCGM Comprehensive Unit, Mumbai, Dr. Ankur Jain from Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi, Dr. Arun V.A. from INHS Aswini, Mumbai, Lieutenant Colonel Dr. Ashok Meshram from INSH Aswini, Mumbai, Dr. Chirasri Sanyal from Nil Ratan Sirkar Medical College and Hospital, Kolkata, Dr. Kartika Senthil from Dharan Cancer Specialty Center, Salem, Dr. Lieutenant Colonel Kundan Mishra from R&R, Delhi, Dr. Mohammad Rizwan Sheikh from Rajiv Gandhi, Delhi, Dr. Nikhil Kumar from AIMS, Delhi, Dr. Nishant Jandyal from Attract and TMC, Mumbai, Dr. Sanjukta Rao from St. John, Bangalore, Dr. Sarthak Vadhera from PGI Chandigarh, Dr. Tribik Ram Panda from Artemis Hospital, Gurgaon, and Dr. Vinod Gurusekharan from Kaveri Hospital, Trichy. To introduce our guest speaker for the day, Dr. Girish Kamath is presently working as Associate Professor in Department of Hematology, STM Medical College and Hospital, Dharwad. After completing DNB in Hematology at Sahyadri Super Speciality Hospital, Pune, he did fellowship in Hematology at Amrita Institute of Medical Sciences, Kochi. He has several scientific publications to his credit, both in national and international journals. He has published several books on hematology and books for PG medical entrance exams. He has recently launched a website, www.howitreat.in, which is a very useful, ready reckoner for junior doctors working in the field of hematology. He will be lecturing on approach to diagnosis in case with Pancytopenia. And of course, the most important activity of the day is to introduce our chief guest of the day who will inaugurate this webinar. And that's Dr. Shweta Bansal from Mumbai. She is senior consultant at the prestigious Sir H.N. Reliance Foundation Hospital. She's honorary pediatric hemato-oncologist and consultant at the Asian Cancer Institute, Mumbai. She's honorary pediatric visiting faculty and the BMT in charge at LTMG Hospital, Sion, Mumbai. She is a postgraduate in pediatrics from Sir Gangaram Hospital, Delhi. She's trained in pediatric hemato-oncology at Rajiv Gandhi Cancer Hospital, Delhi and Tata Memorial Hospital, Mumbai. She did her IOP fellowship in 2011 at St. Jude Children's Hospital, Memphis, and in 2013 completed her bone marrow transplant fellowship at NUH, Singapore. After completing her BMT fellowship, she joined HNRFH and LTMG Hospitals, Mumbai. She was instrumental in starting the BMT unit at both these places and has so far completed over 100 transplants, which include varied conditions like thalassemia, aplastic anemia, Fanconi's anemia, leukemia, neuroblastoma, and immunodeficiency disorders. She has been an active member of the Pediatric Hemato-Oncology Society of India and has served as its treasurer for 4 years. She's member of Ethics Committee of the prestigious Indian Council of Medical Research. She's also served as an editor-in-chief and assistant editor at various PubMed index journals, including South Asian Journal of Cancer, Pediatric Hemato-Oncology Journal. She has been felicitated by Society of Oncology Patna for her outstanding work in the field of pediatric oncology in 2010. She has received accolades for her work and presentations at national and international conferences, including at St. Jude Viva 2010 and COP 2008. I request her to inaugurate our today's webinar and give us some words of wisdom. I'll stop here and hand over the platform to her.
Thank you very much, sir, and for such a kind introduction. And a very good morning to everybody who's attending this webinar. It's always a privilege and honor to be a part of MHG meetings, webinars, and conferences. And I really find myself quite fortunate to be here as a guest, chief guest for this webinar, most famous and sought after webinars nowadays. So today webinar, we all know, is about an approach to pancytopenia. And we have an esteemed speaker, Dr. Girish, with us, who's going to talk us or enlighten us about this topic. And once we go through this topic, we'll all know why the medicine or the medical science is considered as an art. So now, without dwelling much on the topic, I'll restrict myself to the job which has been assigned to me today, is to tell the youngsters why, or inspire them why they should take up hematology as a subject. So I was thinking about it, and I actually some of the events flashed back before my eyes, that what inspired me to take this hematology or pediatric hematology as my, as a specialty. So why pediatrics? Actually, I was thinking, first of all, when I was doing my pediatric, my internship in pediatrics department, I remember that one of the child was brought in a very moribund condition in the OPD, and one of our assistant professor, Dr. Ashu Gupta, at that time, actually, without wasting a moment, just jumped from her seat, and she started doing a CPR and mouth-to-mouth breathing for that child. And the child was completely pink and healthy in few minutes. And I still remember that elation and the satisfaction which we got, that we can save the lives, and actually saving children gives an immense satisfaction. So I decided that I will take pediatrics, and I went to Gangaram Hospital to do my pediatric specialty. And Gangaram had a very, very well advanced pediatrics department with multiple specialties over there and renowned consultants over there. I was most impressed by Dr. Anupam Sachdeva over there, because he was the one person who was actually making a very sick child who's suffering from leukemia or aplastic anemia completely normal, and they were actually come in very moribund condition, and they were walking out of the wards once they recover from it. So I thought I will just take hematology. And most important thing which I really liked about hematology is that Dr. Anupam Sachdeva used to tell me to go to the lab and see the slides. And pathology was my second choice after pediatrics. And it made me realize that while doing a hematology, I can actually satisfy the pathologist in me as well. So I decided to take hematology as a subject. Now, hematology is a very, very interesting subject. It is actually, I would say, there are a lot of advances which are happening in the subject of hematology. We are getting new medicines, which are very costly also. But at the same time, I realized doing hematology that we can treat these patients with very different medicines, with different protocols, and very low-cost medicines also, which I realized in Rajiv Gandhi Cancer Hospital when I was doing my training over there with Dr. Gauri Kapoor. We used to have patients in very sick conditions during febrile neutropenia, and they used to have very high-grade fever. And because of the financial constraints, we were not able to start these patients on antibacterial, antifungal, and antiviral at the same time because of the financial constraints. So we used to have bets whether this patient is having a bacterial infection or viral infection or fungal infection based on the fever pattern or the counts pattern. And believe me, with her experience, she used to be almost 99% correct. And with this, we were able to actually save a lot of money. And I realized that your intuition is very important when you want to be astute clinician. So knowledge is not enough. Your intuition is also very important when you are treating a patient with hematological condition. And similarly, when I came to Tata Hospital, I realized that we cannot just follow the Western protocols. We need to have our own protocols. We need to have our own methodology, which we can with which we can decide which are the protocols more useful for these patients. And I actually continued my training as a clinical research fellow over there. And thanks to Dr. Banavli, he actually taught us like how to think out of the box. And actually, I think with the hematology, I learned that at the same time, you can be an astute clinician, you can be a very good researcher, you can be Sherlock Holmes at the same time, you can be pathologist. And most importantly, it gives you immense satisfaction because you make a very you make a huge difference in their lives. So I think hematology is a very good subject to take. And I hope I have done my job to inspire all of you to take this subject as your specialty. And with this, I would like to end my talk and would declare the webinar open. Thank you so much, sir.
Thank you so much, Dr. Shweta, for sparing your morning, giving this valuable advice to our youngsters as well as the seniors. Your experience over last 2 decades will be extremely useful in guiding them for their future, making career. And thank you for being with us. With that, we come to the main webinar for the day. And Dr. Girish, it's all yours now. Dr. Girish, you're muted. You are still muted, huh, Dr. Girish?
Am I audible, sir?
Now you are audible, but there is echo. You are logged in from 2 sides.
Okay.
You log out from one of the 2.
Okay. Okay. Sir. Sir, am I audible?
You are audible.
At the outset, I would like to thank Dr. M.B. Agarwal, sir, for giving me this opportunity to talk in this prestigious forum, where I understand over 400 people from 26 different countries attend to these webinars. So the topic allotted to me today is approach to pancytopenia. So all of you are aware that pancytopenia means there is decrease in all the cell lines. There is anemia, there is neutropenia, as well as there is thrombocytopenia, and the manifestations can be with the pallor. If there is a neutropenia, patients may present with a severe sepsis, and thrombocytopenia patients may present with bleeding manifestations. So before going to the approach of pancytopenia, I would like to discuss what are the causes of pancytopenia. So first and foremost, the most common cause in India is nutritional deficiencies. And out of that, megaloblastic anemia is one of the most common cause of pancytopenia. Second cause is alcoholism. Alcoholism produces pancytopenia because of nutritional deficiency, direct effect on the bone marrow, as well as hypersplenism because of the cirrhosis of liver. These are certain rare causes of pancytopenia like copper deficiency, anorexia nervosa, vitamin D deficiency. So they also can cause pancytopenia, not very common, but one needs to keep these things in mind whenever they are evaluating patients with pancytopenia. Second common cause for pancytopenia is hematological malignancies, and bone marrows can show either hypocellular marrow as well or a hypercellular marrow. So whenever hypocellular marrow, the hematological malignancies include hypoplastic MDS, hypoplastic AML, hypocellular ALL, or the ALL which have been treated with steroids for some time can have a hypocellular marrow. Hairy cell leukemias, Hodgkin's lymphoma, or NHL involvement of bone marrow can induce marrow hypoplasia. These tumor cells produce some cytokines which can induce hypoplasia of the marrow. Then hypercellular marrows, because of AML, ALL, lymphoma, hairy cell leukemia, myeloma. Myeloma very rarely produces pancytopenia. At a very late stage, they will develop thrombocytopenia. Otherwise, most of the cases of myeloma, in spite of having a heavy infiltration of plasma cells in the bone marrow, they will have normal platelet counts. Then LGL leukemias and MDS. So these are the hypercellular marrows which present with pancytopenia. Then there is a whole lot of drugs or toxins which produce pancytopenia, like NSAIDs, anti-gout medications, antimicrobials, especially linezolid, then ganciclovir, some of the anti-epileptics like phenytoin, phenobarbital, valproate, antithyroid medications, cardiovascular medications like amiodarone, diuretics, some of the psychiatric medications, chemotherapeutic agents, and other medicines like azathioprine, methotrexate, some of the pesticides, organic arsenicals. All these are some of the drugs or toxins which can produce pancytopenia. Next, coming to immunological disorders, like several autoimmune diseases are the causes of pancytopenia, especially systemic lupus erythematosus. Patients with SLE can develop pancytopenia because of the effect of medications that they receive, like MMF or cyclophosphamide. They may develop infections which can lead to pancytopenia. Some of them have splenomegaly, because of which there can be pancytopenia, or autoimmune fibrosis. They may develop HLH, or there can be autoimmune destruction of the cells in cases of SLE. Then Sjogren syndrome, rheumatoid arthritis, eosinophilic fasciitis, sarcoidosis, autoimmune lymphoproliferative syndrome, common variable immunodeficiency, thymoma, pregnancy. These all conditions can induce immune destruction of the RBC, WBC, and platelets, leading to pancytopenia. Then there are several infections. During COVID pandemic, we have seen COVID-19 positive patients had developed pancytopenia, which subsequently recovered with the supportive treatment. Non-ABCDEG hepatitis infection, cytomegalovirus infection, HIV, EBV, parvovirus B19, measles, influenza, HHV6. These viral infections can produce pancytopenia. In ICU setup, when the patient is suffering from a severe overwhelming infection with sepsis, that itself can be a cause of pancytopenia. Mycobacterial infection, brucellosis, ehrlichiosis, leishmaniasis, and disseminated fungal infection. These are some rarer causes, rarer infections which can present with pancytopenia. Then there are several inherited problems like Fanconi's anemia, dyskeratosis congenita, Shortman-Diamond syndrome, reticular dysgenesis, Pearson syndrome, familial aplastic anemias, and some rarer disorders like ataxia, pancytopenia, then telomeropathies. These are some of the inherited problems which can present with pancytopenia, and most of these patients are young children. Then there are some other hematological problems like myelofibrosis, which can be either primary or secondary, paroxysmal nocturnal hemoglobinuria, hemophagocytic lymphohistiocytosis, and idiopathic aplastic anemia. So these are also causes of pancytopenia. Then one of the common cause of pancytopenia in general practice is hypersplenism. Patients who have cirrhosis of liver or portal hypertension because of any other cause can have splenomegaly that can result in destruction of all the three cell lines, resulting in pancytopenia. Then these are all very rare causes of pancytopenia. like transfusion-associated GvHD, orthotopic liver transplantation with fulminant hepatitis, aplastic crisis in hemolytic anemias, radiation exposure, osteopetrosis, hyperparathyroidism, storage diseases like Gaucher's disease, Niemann-Pick disease, metastatic solid tumors. These are rare causes of pancytopenia. Then after evaluating pancytopenia thoroughly, there will be some set of patients who will remain undiagnosed. So those are classified as idiopathic cytopenia of undetermined significance. One should remember that some of the pancytopenias may have multiple factors responsible for it. For example, a patient who is alcoholic may have alcohol-induced bone marrow suppression. At the same time, he can have a megaloblastic anemia because of associated folic acid deficiency, and also cirrhosis can lead to hypersplenism and pancytopenia. So a single patient can have pancytopenia because of multiple causes. Similarly, a patient with HIV infection may be taking heart therapy which is causing pancytopenia. HIV infection per se can induce bone marrow suppression and lead to pancytopenia, and various HIV related lymphomas, they can produce pancytopenia. So coming to the approach to diagnosis. So this is a saying from the famous Chinese philosopher Lao Tzu. He told, rule a kingdom as though you were cooking a small fish. Don't overdo it. So this also applies to patients who are suffering from pancytopenia. All pancytopenia patients need not undergo bone marrow aspiration. That is the rule. That is the thing. So if you do a bone marrow, you may find that these marrows show this is megaloblastic erythroid hyperplasia. But at the same time, one should not underdo the things. Underdoing will lead to overthinking, and you may lose the patient in the process. So pancytopenia also does not mean that you should give all the patients vitamin B12 and folic acid. We recently had one patient who was being given folic acid. Bone marrow showed these are the abnormal promyelocytes, and by the time he reached us, he already had intracranial hemorrhage. So one should remember, we should not overdo as well as we should not underdo the evaluation in patients who present with pancytopenia. So how we can do it is by taking a thorough history, by doing a proper examination of the patient, and by doing some preliminary investigations. So history-wise, one should know, we should take history of duration of the illness, how long it is there. Those illnesses which present with a very short duration likely to be more harmful. They may have acute leukemias, HLH, etc. If patient presents with fever or he has B symptoms, there is a high chance that the patient may be having underlying leukemia. If there are bleeding manifestation, it means the thrombocytopenia is very severe and it needs urgent evaluation, and one should not wait just giving vitamin B12, etc. If patient has a joint pain, it indicates either patient has an autoimmune disorder or he is suffering from something like acute lymphoblastic leukemia. Diet history is important because vegetarians tend to have a high incidence of megaloblastic anemia. If patient is alcoholic, that explains the cause of anemia, pancytopenia. If patient, whether he is exposed to radiation, and this history of drugs and toxins has to be meticulously taken, because there itself we can get diagnosis of many of these patients. Then if there is a family history of pancytopenia, one should suspect whether there is a telomyopathy. So examination wise, one should look for icterus, because megaloblastic anemia patients generally have indirect hyperbilirubinemia and they may be icteric. Lymphadenopathy is generally present if patient is having underlying malignancies. Hyperpigmented knuckles are seen in patients who have megaloblastic anemia. Sternal tenderness is a marker of underlying malignancy like ALL, AML. If bald tongue is there, then again we think about megaloblastic anemia. Skeletal anomalies may be seen in patients who have Fanconi's anemia. Splenomegaly itself can be a cause of pancytopenia, or splenomegaly may be there in patients having ALL or lymphomas, etc. So in a case of pancytopenia, one should make sure these three investigations are sent as the initial step of investigation, that is peripheral smear, LDH and vitamin B12 levels. So peripheral smear may show several changes, and that can give a hint for the diagnosis in these patients. So if the patient has macrocytic RBCs, macro-OLocytes, hypersegmented neutrophils, then the most likely diagnosis is megaloblastic anemia. Virocytes may be seen in patients with pancytopenia, and where the pancytopenia is because of Epstein-Barr virus infection, dengue infection, or other viral infections. Then one may see cystocytes in peripheral smear if there is a development of DIC, especially in those patients who have sepsis. Sometimes one may see blasts or abnormal promyelocytes, which translates you need to do a bone marrow aspiration, biopsy, and flow cytometry and other investigations on an urgent basis. Hairy cells or atypical lymphoid cells may be seen in patients who have NHL spillover or hairy cell leukemia, and pseudopelgarbate anomaly or cytoplasmic hypogranularity may be seen in patients who have MDS. And last is leukoerythroblastic reaction with teardrop cells, which may be seen in cases with myelofibrosis. So peripheral smear examination has to be done by a clinician or the person who is seeing after taking a thorough history examination of the patient. So if a patient is a vegetarian, he has knuckle pigmentation, pancytopenia, macrocytic anemia, hypersegmented neutrophils, there is an indirect hyperbilirubinemia, very high LDH to the tune of 2000, 3000 in that range, and if B12 levels are low or normal, then generally the diagnosis is megaloblastic anemia, and we need to give vitamin B12 and folic acid to these patients. If there is a response to B12, that confirms the diagnosis of vitamin B12 deficiency. So this will solve problem in almost 50% of our patients who present to us with pancytopenia. So in all other cases, and those patients who present with acute symptoms, those patients who have fever, they have bleeding or lymphadenopathy or hepatosplenomegaly or anemia is normocytic normochromic, or LDH is normal, or if there is a abnormal cells in the peripheral smear, all these patients have to undergo a bone marrow aspiration on an urgent basis. Now coming to the approach to diagnosis, I'm trying to tell about approach to diagnosis based on certain case scenarios. So coming to case number 1. So she was a 78-year-old female patient who had presented with fever, oral ulcers in past 7 days. So there was an acute history of fever with oral ulcers, and a hemogram which was done in the local hospital showed that there was a pancytopenia. Hence, she was referred to us. So when we asked more history, she told she had joint pain for past many years, and she was treated in local hospitals. The details were not available, but she told she took some medicines on a daily basis, but she was supposed to take those medicines every week, once in a week. So examining the peripheral smear showed pancytopenia but no abnormal cells. So this is the aspirate which is completely hypocellular. You can see as if there are no hematopoietic cells. All that you are seeing is a fat material. Biopsy also shows extreme degree of hypocellularity. So if in absence of a history of taking some medicines, we could have labeled this patient as a patient of aplastic anemia. So history helps us in understanding what is happening to the patient. So this patient was diagnosed as methotrexate induced bone marrow suppression. Patient was treated with G-CSF, folinic acid, supportive treatment with antibiotics, transfusions, etc. and this patient recovered after 1 week. So one should remember that whenever you have a pancytopenia patient and bone marrow shows a hypocellular bone marrow, that does not mean patient is having aplastic anemia. So hypocellular bone marrow can be because of several causes like hypocellular MDS, AML, partially treated ALL, hairy cell leukemia, Hodgkin's lymphoma, large granular lymphocytic leukemia. So most of the I want to tell to all the participants who are from pathology background that in low power, if you are seeing hypocellular marrow, don't stop at that point. Go to high power oil immersion. Make sure that whatever cells that you are seeing, there are no blasts, there are no hairy cells, there are no large granular lymphocytes, and then you can tell that it is only hypocellular marrow, no other findings are there. Then if patient is having some viral infections like hepatitis, HIV, CMV, parvovirus, HHV6, that also can induce a hypocellular marrow. Anti-neoplastic agents, pesticides, sulfonamides also can produce hypocellular marrow. Then autoimmune diseases, rarely vitamin B12 deficiency can present with hypocellular marrow. And these are all very rare causes. Aplastic crisis in hemolytic anemia, transfusion-associated GvHD, and inherited bone marrow failure syndrome like Fanconi's anemia. So all these patients will have a hypocellular marrow. Once we have ruled out all these causes, only then one should diagnose that patient as he is suffering from idiopathic aplastic anemia or aplastic anemia, what we call. Coming to case number 2, a 45-year-old female who presented with fatigue, vague abdominal discomfort. On examination, she had a massive splenomegaly. Peripheral smear showed pancytopenia. And this was the peripheral smear of the patient, where you can see a nucleated RBC here, and there are many teardrop cells or dacrocytes in the background. So if we see this, we generally get a doubt that bone marrow is involved. Maybe it is myelofibrosis or some bone marrow infiltrative disorder. So bone marrow was done, which showed a very thick bony trabeculae, and bone marrow showed extensive fibrosis, which was confirmed by doing a reticulin stain. So with the provisional diagnosis of myelofibrosis, whether it is primary myelofibrosis, we sent a next generation sequencing for various mutations, but there were no clinically relevant mutations in JAK2, CALR or MPL. Then we did a extractable nuclear antigen test, which showed a positivity for SSA-RO antibody in the serum. So this patient was diagnosed as autoimmune myelofibrosis. She was started on steroids and azathioprine, and subsequently the pancytopenia resolved and steroids were tapered and stopped. So when we see a patient with pancytopenia, bone marrow is reported as myelofibrosis. It does not mean always it is primary myelofibrosis. There are several other causes of myelofibrosis like primary autoimmune myelofibrosis, disseminated TB or histoplasmosis, some of the metastatic carcinomas, other MPNs like CML, polycythemia vera, ET, these can present directly to us in a fibrotic phase. Hairy cell leukemias, renal osteodystrophy, SLE or scleroderma, then radiation exposure, osteopetrosis, and mastocytosis. These all patients can have myelofibrosis. Only when we rule out all these and we do some genetic tests, then we can diagnose these patients as patient of primary myelofibrosis. So this is a criteria, WHO criteria for primary myelofibrosis, where all 3 major and at least 1 minor criteria must be met. So major criteria include megakaryocytic proliferation and atypia, which is accompanied by fibrosis of grade 2 or 3. WHO criteria of CML, PV, ET or MDS are not met, and the patient should be positive for JAK2, CALR or MPL mutation or any other clonal marker by PCR or NGS panel. If this is negative, then one should make sure that there is no reactive myelofibrosis in these patients. So only when these 3 things are met, along with that, there should be either anemia or leukocytosis or palpable splenomegaly or raised LDH or leukoerythroblastosis in the peripheral smear, then it confirms the diagnosis of primary myelofibrosis. So this is a myelofibrosis which is because of the metastatic breast carcinoma. This is a metastatic adenocarcinoma. This is a myelofibrosis which is because of the tubercular disseminated tuberculosis, where you can see a giant cell. And this is a myelofibrosis which is because of the oxalate crystal deposition. Next, coming to case number 3, a 55-year-old male patient who was alcoholic and he presented with, he had anxiety disorder, no other comorbidities, and he had fatigue since 3 months, and he had pancytopenia. His peripheral smear showed macrocytic RBCs and LDH and vitamin B12 levels were normal. So we did a bone marrow for him. There was a marked dysplasia in all the 3 lineages. Almost more than 50% of the cells in the respective lineage showed dysplastic changes. But there was no increase in the blasts. So he was diagnosed as MDS RCMD, refractory cytopenia with multilineage dysplasia, and he was transfused 3 PRBCs. As a routine, he was given vitamin B12 and folic acid, and he was asked to follow up with cytogenetic reports and biopsy reports, bone marrow biopsy report. So after 2 weeks, the patient came back to our OPD, and appetite of the patient had greatly improved. The general condition also had improved, and HP had gone up from 5 to 10 within 2 weeks. TLC had normalized, even the platelet had normalized. So for this patient, MDS was actually not the diagnosis at all. He is a case of megaloblastic anemia, where the morphology was looking as a myelodysplastic syndrome. So whenever we find a patient of pancytopenia with a report saying that it is a dysplastic bone marrow, never jump to the diagnosis of myelodysplastic syndrome. These patients may be patients of megaloblastic anemia. These heavy metal toxicity is again one of the cause for dysplastic changes in the bone marrow. Alcohol abuse can produce dysplastic changes. Infections like HIV, parvovirus, then anti-tubercular therapy, drugs like MMF, chemotherapy, valproate, PNH, then chronic liver disease. So all these conditions can have a pancytopenia with the dysplastic changes in the bone marrow. Only when these causes are ruled out, then one has to make a diagnosis of myelodysplastic syndrome. So this is a paragraph from the WHO book on classification of hematologic lymphoid malignancies, where they say, given all these possibilities, it is extremely important to be aware of the clinical history, including exposure to drugs or chemicals, and to always consider non-clonal disorder as possible etiologies of morphological dysplasia in hematopoietic cells, particularly in cases with no increase in blasts. Hematological follow-up over a period of several months, possibly including repeated bone marrow sampling, may be necessary for difficult cases. So this is given in myelodysplastic syndrome section. So next case is a 45-year-old male patient who was seen in ICU. He was alcoholic, he had pneumonia with sepsis and pancytopenia, which was worsening rapidly. Bone marrow aspiration was dilute. We could not see anything in the bone marrow aspirate. And this was the bone marrow biopsy, where you can see normal bony trabeculae, and in between area is showing extensive bone marrow necrosis. So bone marrow necrosis can be seen in patients who had tumors who are given chemotherapy or steroids in case of ALL, MPN, Hodgkin's lymphoma, etc. Infections like sepsis, tuberculosis, drugs like chemotherapy, interferons, patients with sickle cell disease, DIC, HUA, SAPLA, SLE, anorexia nervosa, and radiation exposure. These all are the differential diagnosis for pancytopenia in patients whose bone marrow shows bone marrow necrosis. Coming to the next case, case number 5, a 12-year-old male patient. He had presented with fever There were no localizing signs. He had splenomegaly, no other physical findings on examination. There was progressive pancytopenia. Bone marrow was done in local hospital, which was reported as a reactive bone marrow with the myeloid hyperplasia. So with no diagnosis to offer, he was referred to us, and his bone marrow slides were taken and they were reviewed, and we could see this hemophagocytosis. This is a large megakaryocytes which has engulfed several hematopoietic elements like erythroid precursors, and there are a lot of debris in this. So with the suspicion of HLH, ferritin was done, which was more than 2000, and triglyceride was 600. So his final diagnosis was HLH. So HLH is diagnosed based on this HLH 2004 criteria. If the patient has a molecular diagnosis consistent with HLH, it automatically becomes a case of HLH. If this is not done or if it is not available, then patient has to fulfill 5 out of 8 criteria. So these 8 criteria include fever, splenomegaly, cytopenias, hypertriglyceridemia or hypofibrinogenemia, hemophagocytosis demonstrated in the bone marrow, low or absent NK cell activity, ferritin more than 500, and high soluble CD25 levels. So these are all the causes of pancytopenia with the cellular bone marrow. There is a lot of cells in this. This can be malignancy, HLH, megaloblastic anemia, Gaucher's disease or Niemann-Pick disease, or tuberculosis. So in these conditions, you find certain specific pathological findings. In some of the conditions, the bone marrow may be totally normal. It may be normal looking, or it may be just a hypercellular bone marrow with no specific pathology. So in those conditions, in that situation, these things are the possibilities, like autoimmune cytopenia. PNH can have pancytopenia even in absence of hypocellular marrow. With a hypercellular marrow also, PNH patients can present with pancytopenia. Then alcohol-induced bone marrow suppression, sepsis-related cytopenia, drug-induced cytopenias, viral infection-related cytopenia, and hypersplenism-related pancytopenias. So this is what we follow. That is, if a patient with pancytopenia is there, first investigation that we do is peripheral smear, LDH, vitamin B12 levels, and folic acid level. If it is suggestive of megaloblastic anemia, treat them as megaloblastic. If there is no response, do bone marrow aspiration. If it is not suggestive of megaloblastic anemia, then we need to do bone marrow aspiration right away. And based on the findings, whether it is hypocellular myelofibrosis is there, myelodysplastic changes are there, bone marrow necrosis, or cellular marrow or normal marrow, there are different differential diagnoses. And by doing other tests and looking at the history examination, we have to come to a final conclusion. So take home message is, each case of pancytopenia is unique. So we need to take a detailed history, examine, then we should come to a conclusion what is the cause of pancytopenia. And identifying a case of megaloblastic anemia solves problems in almost 50% of the cases in the Indian population. And one should remember, bone marrow alone cannot give a diagnosis in rest of the cases, or bone marrow diagnosis should not be considered as a final diagnosis. So data from meticulous history examination must be used for interpreting the bone marrow findings, and ancillary tests are almost always necessary for making a final diagnosis. Thank you.
Thank you, Dr. Girish. Lovely talk, very easy to understand, and you did a great job in educating all of us.
Thank you, sir. Thank you, sir.
So we have some of our colleagues here as faculty, and they may like to ask some questions to you. We start with Dr. Sanjukta Rao. Others can be ready by using the raise hand sign, and the audience can put the question in the chat box. Sanjukta, go ahead. Oh, you are not audible.
I'm not?
No. There's a lot of background noise also.
Bangalore traffic, I think so.
Are you?
Am I audible now?
Echo. in from two sides. You come out of one side, log out from one side.
No,
You're still logged in from two sides with echo. Okay, meanwhile, we'll go to Dr. Tribikram Panda.
I managed to log out of that site, sir. Is this
Yeah,
better?
okay. Dr. Sanjukta, now fine, go ahead.
So sorry. So Dr. Girish, thank you very much for that talk. So we get a few referrals from Nimhans because it's our neighbor. We get a lot of patients who have Wilson's disease and have varying degrees of pancytopenia. And we know that there are multiple causes for pancytopenia in Wilson's. And often one of the possibilities we think of is deep and induced pancytopenia, one of the drugs you mentioned. And usually they're not very happy, want to introduce penicillamine. Is there any way you think, do you have any way around this? Like usually would have done a marrow, there is some element of splenomegaly. So because of the liver disease and Wilson's. So all of this can contribute. But one of the things that we think is possibly reversible is penicillin. So is there any way you can see around?
Ma'am, there are in your case, this is looks like more like a multifactorial thing.
Yeah.
Copper per se in a very high level can be a thing which can suppress the bone marrow. One. Second, these patients may have hypersplenism related pancytopenia. Third, we have seen 2-3 cases of Wilson's disease where they had presented with hemolytic anemias. Our gastroenterology counterparts say it is not very rare, but for us it was quite a rare thing. We evaluated quite a lot, but finally the patient had a KF ring and other ceruloplasmin and other things confirmed that the patient had Wilson's disease. These are some of the things which we should think about whenever we are evaluating a cytopenia in patient with Wilson's disease.
Okay, my second question is, again, we have patients with failure, dialysis dependent renal failure,
Yeah.
who have varying degrees of cytopenia, and most of them are adolescents and young adults.
Yes.
And the workup is usually a non-contributory. Our metabolic parameters, all of that, and common association with dysfunction and even PNH, myeloma, all of that.
Correct.
That is negative. So is there
Correct.
anything you think we should be looking into in this population?
We also tend to get these kind of cases. Many times it could be a toxin mediated. They're not being appropriately hemodialyzed. These whatever toxins are there, they may be harming the marrow. Second thing is if the patient has been transplanted, they use lot of medicines like MMF. They use GAN cyclovir. So these are some of the if you see very carefully, there will be certain medications which are actually causing pancytopenia. You try to adjust the doses, then generally this pancytopenia resolves.
Okay, so most of these patients are in the transplant phase. They refer to us because of cytopenia transplant. That's the issue there.
And also we need to see if they are young, what is the actual cause for their renal failure, whether it was autoimmune disease which caused whether they have SLE, and that particular the original disease that caused CKD may also be the responsible thing for development of pancytopenia.
Yeah,
so marrow normal, then we need to think about these things. Many times what happens, small contracted kidney biopsy cannot be done.
yeah,
They
exactly.
are just left as cases of CKD undiagnosed. The rest of the life they undergo dialysis, or if a donor is available, they undergo transplant. Many times we have seen they are not adequately evaluated for knowing the cause of CKD.
Yeah, exactly. We don't know the cause because of shrunken
Yeah.
dilemma that we face.
Yes.
Thing is, Girish, some young patients, they're otherwise very well.
Yeah.
About 16 years spleen. And we know that it's probably hyperthyroidism, and even for marrow, we don't really offer them anything. Do you think it's not to do a
Your audio is not clear, madam, but if it is not a case of megaloblastic anemia, I would anyway do a marrow for any patient who has pancytopenia. If it is very clear-cut vitamin B12 deficiency, we don't do marrow. But any other, even if there is a strong history of drugs or other things, it is better to do a marrow and tell them that marrow is normal. It gives a lot of reassurance for the treating doctor as well as the patient.
Thank you. One more thing you touched upon, HLH.
Yeah.
So one call that we get is from the ICU because the patient has pancytopenia. And invariably, most patients with HLH, which sepsis and multi-organ dysfunction, you look at the HLH probability, it's invariably high.
Yeah.
Any comment on that? Good to have a high index of suspicion, but are we ending up over-diagnosing HLH? That's my problem.
No, what I have observed is it is very often underdiagnosed, madam, compared to those patients. If they are fulfilling 5 criteria out of 8, 2 criteria in India, it is very difficult to get CD20, soluble CD25 levels and interleukin, those things. But out of 6, if 5 are met, it is always better to take them as HLH. Even if you don't give etoposide, it is all right, but you can very safely treat them with steroids and cyclosporine. So many of the patients can be salvaged. If you don't intervene, most of them will anyway die.
Are you seeing any other heart drugs, HIV active antiretroviral therapy drugs causing pancytopenia? Because earlier it used to be zidovudin and stavudin, and none of the heart regimes are containing these anymore. Are you seeing any of the newer heart drugs causing pancytopenia?
No, we just take it as heart which causes. I don't have any special experience in this. But if somebody is on heart, we generally attribute it. Marrow is normal, then we stop it for some time and it recovers.
That's it. Thank you.
Thank you, Dr. Sanjukta. Dr. Tribakram Panda.
Good morning, sir. Am I audible, sir?
Yeah, you are audible.
Sir, it was an excellent clinical vivid speech. So whatever I learned, I would like to again revise. That is, in every case of pancytopenia, sir, as you told, peripheral smear examination, and before that, history and physical examination, that is a must. So coming to my question, sir. Sir, what is your talk on how do you encounter the gelatinous transformation of bone marrow? We have 2 to 4 cases. We have seen patients, they have presented with bicytopenia or pancytopenia. All were females in their 30s to 40s. And basically, there is extensive, the pathologies they gave, there is subsequent extensive gelatinous marrow transformation leading to cytopenia. We gave them vitamin B12, and 1 to 2 patients we also gave TPORH, and the marrow recovered. So what is your experience on that?
Whatever is our experience, we have seen those patients having long-term starvation. They want to lose weight. Especially these will be the young ladies, if you see.
Exactly, sir. Yes.
And you try to give them some B12 and improve their nutrition. Generally, the pancytopenia resolves. Another common cause for gelatinous transformation is HIV. HIV also can have, and some rare viral infections. But generally with the nutritional replacement, they recover. And
Exactly.
what I want to highlight one more thing today is most of the people who are attending may be students. Make sure you don't end up your evaluation at the point of history examination. Always your evaluation should include a peripheral smear evaluation by yourself. Then you will get lot of inputs about the patient, and also try to see bone marrow by yourself. Never completely rely on pathologist. You yourself should learn how to examine the marrow.
Exactly. Sir, coming to the drug-induced pancytopenia, have you encountered, we have encountered many patients, those who are on weekly 5 milligram of methotrexate. They develop
Yes.
such florid pancytopenia with oral mucositis and all, maybe a idiosyncratic reaction to methotrexate. So, what is your experience on weekly low-dose methotrexate and drug-induced cytopenia with vivid mucositis and toxicity?
Yes, we also have encountered like that few cases where they have taken only weekly. We, in spite of repeatedly asking, they say that we are taking it weekly. Maybe it is there is associated folic acid deficiency. Many times these weekly doses they give once in a week methotrexate. Rest 6 days they give folic acid. Probably that will help these patients. Not sure, but yes, as you told, patients who are not being over treated or they take accidentally more methotrexate, those who are taking a therapeutic dose of methotrexate also can develop pancytopenia.
Sir, one more question, sir. Sir, what is your threshold of doing a bone marrow aspiration and biopsy when we get any call for a sepsis-induced maybe cytopenia in ICU setting, as my previous speaker, she asked. So most of the cases we suspect clinically either HLH with high serum ferritin and in the background of hypofibrinogenemia, hypertriglyceridemia. So what is your threshold on doing a bone marrow aspiration and biopsy in those settings? ICU or sepsis?
No, our threshold is very low. Our threshold is very
Yes,
low.
yes.
If patient
Yes.
has pancytopenia, even if it is sepsis, they have called us for evaluation of pancytopenia. It is better to do it right away. Many times what happens after 1 week, after 10 days, we do a marrow and we find that there is HLH. Then the patient may not be even fit enough to give any kind of treatment. So if the primary treating physician suspects there is some hematological issue, he has called us for evaluation. That should always include bone marrow.
And sir, what is your take on role of NGS in?
And one more thing, in such cases, it is always advisable to send a bone marrow aspirate for the blood culture. You send the bone marrow aspirate in blood culture. That is a very rich source of the infection. Many times we can pick up salmonella. We have picked up so many infections when bone marrow is being cultured for the bacterial infections.
Yes,
and,
sir. We routinely send sir for blood bacterial culture, fungal culture, and mycobacterial culture also from bone marrow sample.
Yes.
Sir, one more question is, what is your take on the role of NGS, next generation sequencing, in unexplained pancytopenia? So where do you send that in unexplained pancytopenia? I have seen many clinicians, they are sending clinical exome sequencing or next generation sequencing. So any experience?
No, we generally don't send that.
Okay,
My
sir.
experience has been that.
Okay, sir. My final question, sir. Sir, how do you approach partially treated ALL? Partially treated ALL with hypoplastic bone marrow with suspicious history of sir taking intake of some alternative Ayurvedic products, no definite evidence, just wait and watch.
Very common. This is very common scenario, at least in our setup. We don't treat them as ALL anyway. We just put the patient on folic acid. We wait till it relaxes. There is a frank relapse. Only then we repeat a marrow and then send the sample for flow, confirm it, and then treat. That has been our policy. But the alternatively, what you can do is you send the biopsy log for IHC. You may get a fair idea that it is ALL, and then continue with the therapy, that is possible, but it is better you wait for some time, let it relapse, and then you treat the patient.
Okay. Thank you, sir.
Thank you, Dr. Panda. We'll take one question from the audience. Dr. Neeru Singhal wants to know, in pancytopenia, which has the worst prognosis? Low hemoglobin, low WBC, or low platelet count?
Sir, it is low, as per me, it is low WBC count. RBCs you can give, platelets you can give, but neutrophil count of 100 or 200 may kill the patient within hours. So I'm more worried about the ANC rather than anything else.
Thank you, Dr. Girish. Dr. Amit, your question.
So, sir, does PNH clones in severe aplastic anemia rules out inherited etiology?
Generally, yes. If we do a PNH and there is a PNH clone, very unlikely that the patient is having something else like Fanconi anemia or other abnormalities.
Okay.
Any other question, Amit?
No, sir.
Okay, Dr. Nikhil.
Thank you for the excellent talk, sir. It was very informative. I have a couple of questions. My first question is, in a young patient, 20, 30-year-old presenting with pancytopenia, after extensive evaluation and other causes being ruled out, a bone marrow examination shows a mildly hypocellular marrow. The degree of hypocellularity does not fit into the criteria for a definitive diagnosis of aplastic anemia. And very often these patients are placed into a diagnosis of a probable evolving aplastic anemia. What is your experience regarding this, sir? And what would be your threshold for starting immunosuppressive therapy in such patients?
Unless these patients fit into the diagnosis of aplastic anemia, we avoid giving any kind of immunosuppression. What we have observed is those patients who have a patchy marrow, there are some areas of hypercellularity, some areas of hypocellularity, looks like evaluating aplastic anemia. We need to really evaluate them for autoimmune disorders.
Okay, sir.
If there is an underlying autoimmunity, they tend to have such kind of a morphology. I mean, biopsy will show such morphological changes. Again, as you told, PNH can have something like that. There are some areas of hypercellularity with evolving aplastic anemia. So I would not start them on ATG unless there is a diagnosis of aplastic anemia is confirmed. Less than 25% cellularity has to be demonstrated, or we are missing something else. We need to really look for that.
Yes, sir. In case, sir, all other causes, including autoimmune, PNH, other causes are ruled out, and patient is having progressive cytopenias, and the marrow cellularity remains maybe like slightly hypocellular, 40-50%, yeah, maybe hypocellular for age. Would you consider giving cyclosporin eltromopag in such patients, or would you observe till the marrow cellularity comes down?
I think I will observe. If he is not transfusion dependent, it is better to observe. If the platelet count is around, like many of the viral infections also can have like this, they may recover on their own. So it is better we avoid finalizing the diagnosis of aplastic anemia on these patients, because they may end up with a transplant somewhere else. So before you diagnose some patients as aplastic anemia, it is extremely important. Make sure you are not missing anything else. I told you about several other causes of hypocellular marrow. So always try to, you may wait for, in such cases, you may wait for a couple of months also, if they are not transfusion dependent. And then you can take a decision whether to do a transplant or ATG, etc.
And sir, when would you repeat a bone marrow examination this type of patients? Would you follow them up, or maybe after 3 months?
Depends on the severity of cytopenia. If it is dropping too fast, maybe you will do it early. If it is hovering at the same place, you may take some more time. If it improves, then you may not do a repeat marrow at all.
Yes. So my second question is in a post-transplant setting. Many patients after allogenic stem cell transplant, especially patients who have had a CMV infection and they have received ganciclovir or valganciclovir as treatment, they develop cytopenias after that. And many of these patients, these cytopenias remain for a very long time, even after stopping these medications. And such patients, when we do a marrow and there is no disease and the chimerism is at 100%, when would you label such patients as a poor graft function? That is, patient who has 100% chimerism, full chimerism with multilinear cytopenias. And in such patients, what would be a threshold for starting L-Trombopag?
I think L-Trombopag can be started in such patients. If there is a full chimerism, it is difficult to tell that this is a graft failure.
Right.
We may use L-Trombopag, we may use GCSF, give them transfusions, look at the drug list and make sure all the drugs which are causing pancytopenia are taken off. Probably with that, things should settle down.
Yes,
As long as there is a full chimerism, it's difficult to label them as graft failure.
Yes,
Primary or secondary, whatever.
So would you label them with a poor graft function, or would you attribute it to the infections or some other cause that
Generally,
they had
if there is a full chimerism, I will attribute it to some other causes.
Okay. Thank you, sir.
Thank you, Nikhil. One more question from the audience. Dr. Tirumebhat wants to know, there's a case profile for you. The 36-year-old male, he has symptoms of anemia for 3 months. There is some amount of weight loss. Spleen is 6 centimeters below the costal margin. No lymph nodes, no enlarged liver. So symptoms of anemia, 3 months, some amount of weight loss and splenomegaly. There is pancytopenia with hemoglobin of 6, normal MCV, WBC 1200 with neutrophil 22%, and platelet count 12,000. LDH normal, uric acid normal. Bone marrow is hypoplastic. So you got pancytopenia with hypoplastic marrow and a spleen of 6 centimeters and 3 months history with 36 years age. What will be your diagnosis, or how will you proceed further?
Sir, first thing that has to be done is a IHC on the bone marrow biopsy, because some of these hairy cell leukemias, large granular lymphocytic leukemias, they induce bone marrow hypoplasia, and especially in if somebody has a splenomegaly, I would avoid calling these patients as a case of aplastic anemia. And if IHC also is negative, it is not picking up any abnormal cell population, then it is advisable to do a PET CT in these patients. If PET shows any lymph node which is biopsyable, or even at least a core needle biopsy can be done, it is better to do that. If that also comes negative, it is better to take out the spleen and see if anything is there in the spleen. That may be sometimes even curative for these patients.
Thank you, Girish. We have one more question from Dr. Vinod Gunasekharan.
Sir, actually, it was a very simple and practically useful approach that you have discussed. So, like my few questions include, like, first one, especially in a dengue outbreak, like most of the children usually resolve within a week or so, but some may persist to have fever, pancytopenia more than a week, and we evaluate them for HLH. So ferritin will be high, triglycerides will be high, fibrinogen will be low. So in such scenario, like where we have a proven case of dengue with secondary HLH, number one, do we compulsorily need a bone marrow to treat the HLH? Number one. Number two, like what would be the treatment regimen we follow in a secondary HLH post dengue? Like what we see is a very short course of steroid will be sufficient. So just want to know your approach in that as well.
Exactly the same thing happens here also. We see a lot of dengue cases with pancytopenia. We invariably do marrows in these patients. There's a small study which is going on, just to make sure that these are HLH cases. And if HLH is proven by the criteria that has been set in, we just give a very short course of dexamethasone, maybe for 3 days, 4 days. And we have even followed up these patients, and none of them ever had again occurrence of HLH. A week of or even less than that course of steroid generally helps in these patients, though it is not mentioned in any of the books or anything. This is a purely personal experience.
Okay, thank you, sir. Number 2 is like again B12 deficiency, which is the common cause for pancytopenia. There are different regimens followed in different places. Oral, parenteral, again in parenteral, different doses. Like, what would be your approach? Like,
we generally give 1000 mg, 1000 micrograms every day for 5 days, every week for 5 weeks, then every once in 3 months for rest of the life. This is what we follow. I understand that this can be different in different places, but this is the protocol that we follow.
There is a pure.
We don't give oral B12 for whatever reason. We rely more on the parenteral.
So even if there is poor dietary pattern, like pure vegetarian or this, like, can we try oral or what's the take?
Sir, once in 3 months should be fine, rather than advising them to eat more of non-vegetarian and other things. It is better to tell them that you take once in 3 months and continue with your dietary habits, whatever it is. That it's very difficult to tell them. Those who are strict vegetarians, it is better not to get into their food habits and other things.
Thank you, sir. The next question is like in aplastic anemia evaluation, like now we have this gene testing widely available for inherited bone marrow failure syndromes. Like, what would be the role of doing this chromosomal breakage study? Like in peripheral places, it might be difficult to do this test at times. So can we omit that if we have a genetic report in hand, or still we have to establish this chromosomal breakage?
We practice in a peripheral center only. With present logistics, getting a stress cytogenetics is not really difficult. We can get a stress cytogenetics. If it is positive, we end at that point. If we have a very strong suspicion based on the clinical features and other things, family history, etc., only those cases we send them for NGS panel for inherited bone marrow failures.
Sometimes like the karyotype is always tricky. Sometimes the no metaphases identified. All those reports.
Yeah.
Again,
maybe in those cases it is better to do, but it's little difficult to interpret some of the reports that we get.
Understood. Yeah. And the last question is like, now that practical question, the L-Thrombopag, the Indian brands. Yes, sir. Please.
Then Girish, I'll just like to add one thing here. In Fanconi's anemia, there are 60 plus mutations. The stress cytogenetic test becomes the only comprehensive test to cover everything that's happening to the patient. So the NGS panel is not a replacement for stress cytogenetics, number one. Number two, you don't have to do the bone marrow for doing the stress cytogenetics. You can do it from the peripheral blood lymphocytes. So,
yes. Agreed.
So you have to do the stress cytogenetics. NGS is not a replacement, and you can do it from peripheral blood. The quality of marrow is then unimportant, right? You can go to your next question.
The last question. Thank you, sir. Thanks for making this clear. Now that practically this L-Thrombopag, the Indian brands which were quite cheaper than the original brand, is not available in the recent few months. And now that we have Romiplastin, Indian brands which are like in calculation becomes cheaper than giving L-Thrombopag. Like, what is your practice in aplastic anemia while adding a third drug along with ATG cyclosporin, Romiplastin versus L-Thrombopag?
Yeah, you can add that in a very high dose, 500 micrograms every week, in that range.
In aplastic anemia.